You're tuned into RX Radio. Movement prescribed. Brought to you by Prescript.com. A personalized approach to keeping you healthy and making your best even better. Your hosts, Dr. Jordan Shallow and Dr. Jordan Jinta.
What's going on, guys? Welcome back to another episode of RX Radio. Really excited for this one. It's a topic I've wanted to tackle for a long time, but you guys know I like to kind of stay in my lane with this stuff, so we're usually all sort of mechanics and function, and I've always wanted to have someone the other side of the aisle that's world-class in the structure field, and Dr. Adeel is definitely that. So Dr. Adeel Khan is a physician specializing in regenerative medicine in Toronto, Ontario. He works at the Gallia Clinic, which, like, those who know Tony Gallia. So when I tore my pec a couple of years ago, my first phone call wasn't to my mother. It wasn't to the hospital. It was actually to a friend of mine, Ben Pekulski, and then Ben, his first phone call was to the Gallia Clinic. So when it comes to regenerative medicine, you know, these guys are top of the game, and they're really spearheading and pioneering the initiative in forwarding both the legal and medical side of regenerative medicine. And Adeel is young dude, and frankly, when it comes to education in Canada, like, and I even tell him this, like, if I had to make up a resume of academics in Canada, it would be it. Just the top of the line when it comes to his schools, his internships, and obviously his career. And he does everything from talk about peptides and, you know, the promising aspects of peptides, the potential limitations and drawbacks, common misconceptions around stem cell, PRP, prolotherapy, and really outlines like a gold standard that you should be looking for if regenerative medicine is kind of in your wheelhouse. Unbelievably smart in his ability to synthesize some very complex topics. He talks about sort of the three things needed for regenerative medicine. If you're into this kind of stuff, and if you're an athlete or work with athletes, I really think it's pioneering and trailblazing a whole new way to look at injuries and how we can co-manage injuries multidisciplinary. So, you know, it's great to hear Adeel talk about the importance of function, you know, and he gives some pretty wild case studies. If you guys don't follow him on Instagram, we'll put it up in the show notes. Dr. A. Khan, on Instagram, he posts some stuff super informative and super just like tangible when it comes to, you know, diagnostic ultrasound guided PRP injections, first generation, second generation PRP. This is going to be something that you see a lot. You're going to hear his name on the podcast again. You're going to see his face on my social medias when I get back to Toronto, with, you know, the athletes that I work with and sort of the sporting world that I'm in. Regenerative medicine is something that is really going to give you a leg up in the competition and accelerate things, you know, hopefully pre-injury, but more importantly, you know, post-season, post-injury. This is going to get people back on the field a lot quicker, and you know, with the science that they're doing, this is really going to accelerate that process. So hand in hand, tandem, we're talking about doing some seminars together when we get back. So guys, no further ado, Dr. Adeel Khan, regenerative medicine physician out of Toronto, Ontario. I hope you guys enjoyed. Do follow on Instagram if you have any questions. He's very receptive and very knowledgeable on the topic. I can't think of anyone better than Adeel. So I hope you guys enjoy. We'll see you next week.
I read that thing you sent me, and so my sister's a physician, and I never empathize with like any other profession, because a lot of people don't know what I do, and I get like the same, like, oh, can you crack my neck? And I'm like, oh boy, oof, this is going to be a rough conversation. But then I thought about like what you must do, because like people come to me with like regenerative medicine questions, and it's basically kids in the DM going like, yo, I got this CJC. It's like some weird NASA explanation of like peptide. I'm like, should I do it? I'm like, probably not. No, you should probably give that back to your friend. But I guess like I've never considered so much misconception around the field of like regenerative medicine until like I started reading through it. I was like, oh, that must be really frustrating for you to like dedicate your life to something and people have no idea what it's about.
Yeah, exactly. And like you said, there's a lot of misinformation. So, and that's part of the issue, is because of American, you know, physicians, as well as, you know, physicians in Mexico and Panama and all these places offering like IV stem cells and like stem cell treatments to kind of cure everything. And then it becomes kind of like a catch-all. And then people come in expecting that stem cells can fix them, like, you know, and fix like all these different ailments that there's no evidence for. And so that's part of the issue. It's regulation, right? There's not enough regulation in the other countries, and Canada's kind of gone the other extreme though. Like Health Canada actually, like, they banned stem cells last year. Like, so they're not allowing use of them for like outside of like very specific like hospital uses for like patients with like like leukemia and who need stem cell transplants and that kind of thing. So it's there's a middle ground though, where I think in Europe, where they tend to be more open to that kind of stuff, and they have enough regulation, but not kind of crazy either. So I think that's where we gotta go.
Now, like, regenerative medicine has like a fairly recent history, right? Like, I remember reading about stem cells or hearing about stem cells when I was like, I don't know, maybe 15. It was something to do with like, was it Christopher Reeves? Like, he was like the Superman that got like paralyzed or something like that, and then all of a sudden, like, stem cells that was like at least the emergence of it on my front of like, okay, this is like a thing that's contentious. And then there was like an ethical, religious battle about what stem cells were. Like, what's like a brief history of like regenerative medicine, or is it not brief at all? Like, how long have we
Well, yeah, so it was actually Dr. Arnold Kaplan from Case Western University who came up with the word mesenchymal stem cells, MSCs. And he coined that word in like the early 90s. And it's kind of like that pathway. I don't know if you've seen those, like, like basically different progenitor cells that can differentiate into, into muscle or into, into bone or into tendon, depending on what you're trying to achieve. And he kind of came up with that term back then. So that's when it really probably first started, like early 90s, I would say. But in terms of where it's headed, though, now we realize it's not stem cells per se. The better term for it is actually medicinal signaling cells. So he's actually wanted to recoin the phrase, but unfortunately people are still using the word stem cells. So stem cells is actually a misnomer, and it's not even an accurate term, because it's not the stem cells themselves. It's the signals that those cells send that help to differentiate or turn into like, whatever you're trying to achieve. So for example, if you're like, we do sometimes adipose derived cells, and when we take it from the fat, they send signals into that local area where we inject it, and that local area where it sends those signals, it tells your body to kind of basically heal and differentiate into like tendon, for example. So it's more the signaling molecules as opposed to the stem cells themselves that are involved in kind of creating or regenerating tissue. So that's part of the problem. A lot of people think when they think stem cells they're like these miracle, cells that you're harvesting, but they're not really. It's really the messengers that they send that causes the healing effect. And so it's actually local signaling cells that cause the healing, not so much the stem cells themselves. So that's
on a day to day, like, how many different like compounds do you have to deal with as far as like what you're putting into people? What's the variation of like, if we're trying to target, I don't know, bone versus muscle versus tendon versus ligament, what is the spectrum of actually like injectable compounds that have efficacy in like in a medical realm, like in your clinic? What's the span? Like, is it 1? Is it 2? Is it 100? How many different one of these like signaling compounds can you pull off the shelf and actually put into someone?
Well, yeah. So there's regular first generation platelet-rich plasma, which is like the PRP, which is basically where you take your blood, you spin it, you centrifuge out the platelets, and those platelets have signaling cells that help with healing. So they have something called cytokines that reduce inflammation and that help to heal, in terms of tendon or cartilage. And so that's kind of the most common one. And now we have something called a second generation platelet-rich plasma, where we actually you actually modify it a little bit. So you put it through a process where you remove some of the catabolic cytokines. So essentially what you're doing is you're taking out some of the pro-inflammatory messengers, so you have more of the anabolic signaling. So it's a bit more specific for the injury, or for example, in chronic like osteoarthritis, the underlying physiology is that it's because of chronic inflammation and damage to the cartilage, right? And so what we're trying to do is we want to target that chronic inflammation, and you can target it better if you remove some of those catabolic cytokines. And so you're getting, so it gets more specific that way. And then the other one is adipose derived stem cells, or bone marrow derived kind of stem cells. That's just what we call them. But again, stem cells is probably not the correct word, but everyone just says that. But so those ones are more, for us, the way we use that is more as like a scaffold to help regenerate tissue. And what the fat specifically does is it can hold like a large tendon tear. It can hold it as a scaffold, and then you can seed it with the platelet-rich plasma, which has growth factors. And then you kind of have what's called the cell proliferation triangle, which is basically, the growth factors, like the scaffold, and then like the cell signaling from the platelet-rich plasma. So, and that kind of is how where tissue regeneration is kind of headed. And the biggest issue is the scaffold to get true regeneration. So, for example, because for example, with osteoarthritis, you get wear and tear of the cartilage. And so what you're doing because a lot of people, they come in and they ask you, you're like, oh, can't you regrow the cartilage? Like, aren't you gonna, what if like the PRP or the stem cell, like I'm gonna get stem cells and my cartilage is gonna regrow, right? And that's what they think. And unfortunately a lot of doctors have sold that to them, and it's not the truth, right? There's a very, very minimal effect on the cartilage, on the volume and thickening of the cartilage. And most of the effect is actually just anti-inflammatory. So it reduces inflammation and pain and gives you more quality of life that way. But the regenerative effect is actually quite minimal for cartilage. The only way to get a sufficient regenerative effect would be if you had like a scaffold. And so that's actually a very active area of research for cartilage. They're using, in Europe, what they're doing is they're using 3D bioprinters, and they're using hyaluronic acid derived molecules to create a scaffold. And then you see that scaffold with stem cells or PRP, which have growth factors in them. And then that can actually regenerate cartilage to a more, sufficient, like kind of the idea of regenerating like cartilage or joints that's the future. And that's kind of, that's already being studied and being done. So it must
be so frustrating for you. Like as equal, like I can only imagine, especially with like the athletes you work with, because I feel like athletes, they're good at one thing. They're good at their sport, and they're not medical students for a handful of reasons. They're not medical students, and they come into like, especially in the bodybuilding community, like with the popularity of like, research peptides and this idea in their head that, Dr.Khan, Adeel sitting there with the adamantium injection, just like, oh, I got you, bro. You're gonna tricep tendon, just
exactly.
Fucking 5 mils to freedom right in the elbow. It's like, what is the most difficult part in overcoming people's misconceptions in a clinical practice?
Well, I think it's telling them the truth about what they can and they can't do, right? It's basically that idea that the regenerative effect is actually quite minimal and it's more anti-inflammatory. And to have a true regenerative effect, you need a scaffold. And so we can achieve that regenerative effect with like muscle and tendon tears, because we can use the fat to a certain extent. But people, when they come in for like other like joint issues, like the regenerative effect is very minimal. And that's the biggest area, I think, where we have to kind of counsel them and be like, well, we can't really regenerate your joint. Like we can only help like fight the inflammation and maybe have a little bit of regenerative effect. And like I've had people come in and like pro bodybuilders especially, like where they'll be like, I'm thinking of going to Panama to get like IV stem cells done because they'll fix all my joints and muscle ailments. And I basically have to spend like an hour talking them out of it. So,
well, I've had to do it. I know someone. So Adeel Khan, he's like a pretty famous.
Oh yeah,
he's like one of the greatest. I think he went down to Panama. It's like, dude, Panama's a fucking shortcut. It's not even a country. What are you doing? And I was very sure he went down there and got the whole thing like for his shoulder or something like that.
Yeah. And I'm sure like there are success stories here and there, but there's also risks with them, right? And you don't know. There's not enough studies on like long-term data, and also you don't like what are IV stem cells going to do, right? Like it doesn't make sense, because like we were just talking about earlier, it's the local signaling cells that these things that we're injecting, that's where the benefit is derived from, right? It's the signals that they send locally. So when you're putting them intravenously, you just don't, like, what are they going to do throughout your body? Like, how do you know what effect they're going to have? Or what if they there's been case reports of, for example, someone doing like IV stem cells, and like instead of like like it was for like an eye issue, and instead of it differentiating into like the local tissue, it turned into bone, and then the person went blind. Like I've heard of, yeah. So like,
shit.
so there's been case reports and stuff like that. Yeah. So like, it's like, and that's like, people don't realize that, right?
Well, it's got to be frustrating, man, because like it is an emerging, like, red light, infrared therapy, saunas. People are shining like flashlights up their ball sack every morning. Like, it's got to be so frustrating for you as like this is. I've described you to like a handful of my friends since we started talking. It's like, imagine if you had to go to a bar in downtown Toronto and make up a fake work resume and like academic history to try and pick up a chick. It would totally be your story. I would totally give that. Oh, so what do you do for a living? Well, here, let me tell you. My name is Dr. Adeel, and I went here for school, here for school. It must be so frustrating to like listen to a podcast and just be like, wrong.
Well, yeah, exactly. And then that's regenerative medicine is just one of those areas because it's like, it's pretty cool. It's just cutting edge. There's a lot of like, new research, but then at the same time, there's a lot of people who are just kind of gimmicky and like, they don't really know their stuff that well. And they just go on these, well-known podcasts. Like, I mean, Joe Rogan, I think he had Ben Greenfield, and he had, was it Mel Gibson? I think his dad or someone went to, and they had, they talked about IV stem cells and all this stuff. So that caused a lot of people to be like, oh, this is like the next big thing. And then, that's the issue. You got to really, look at the science and differentiate between like hype versus actual like evidence-based stuff.
What is the most common success story? Like, what would be good exclusion criteria with like the current body of like evidence, given your experience and what research can show? Like, what conditions are maybe top of the list of like, okay, this is something we treat regularly. This is something that's commonly occurring with not even general population, but with athletes. And this is a good marriage of symptoms and treatment for regenerative medicine.
Yeah. So I think, so definitely like, I mean, the top one is definitely like muscle or tendon tears, especially, obviously that you can have acute injuries where, for example, if you have a sprinter and they pop their hamstring and they want to get back as fast as possible. We know that if you do like a platelet-rich plasma injection, it can cut the healing time in half. And then you can actually see, the tendon or the muscle heal on ultrasound too. So you have like sonographic evidence to tell them, okay, now you can get back to like, progressing and strengthening and everything. But chronic, it works really well for chronic muscle tendon tears as well. So like, there are a lot of people who might have like chronic nagging injuries, and they might just be like, oh, like, I see my therapist, it's like, man, just for a bit, but then I just have this like, for example, like a chronic pain in my lower back and it just won't go away. Like, and it's like a very localized spot. And then cases like that, we often find muscle tears that just didn't heal. And those are great responders to like PRP injections. And usually you only need like one or two, and then it can fix a problem that's been there for years even. So those are really great ones. And then the biggest other one is osteoarthritis, which, is the wear and tear of like the cartilage of the joints. And so you can, even for mild to moderate osteoarthritis, you can do the regular PRP injections, and they work quite well. And they help mainly with inflammation, and they have a minimal regenerative effect on the cartilage. But for more advanced arthritis, this is where, people are offering stem cells. Like if you go to the US, you can pay $10,000 and get a stem cell treatment for your knees, but it's not really regenerating the cartilage, right? It's just sending signals to the local cartilage tissue to help with reducing inflammation and maybe a minimal regenerative effect. Remember, you need a scaffold to actually regenerate tissue, and there's no scaffold that they're injecting. You're just injecting cells. So you're not actually regenerating, truly regenerating tissue. So for advanced arthritis, where you have subchondral like bone edema, where you get inflammation underneath the bone, for that, we're actually doing something called intraosseous injections. So but we do it under conscious sedation in an operating room. but it's not as bad as it sounds, because you actually put some freezing and stuff, and you don't feel too much. But it works amazing, because if you think about it, the studies show that in osteoarthritis, narrowing of the joint doesn't actually correlate with symptoms. So, for example, people can have yeah.
Say it again for the people in the back looking at X-rays. Fuck.
Well,
me,
exactly.
man.
Yeah, that's the issue,
listen
right?
to a real doctor. Holy fuck.
People, they can have their doctor will be like, "Oh, you have bone on bone. You need a hip replacement." Like, I've had so many patients, and it's just like, "What are you talking about? Like, your symptoms, like, you're functioning fine, your range of motion is good. You're like, you don't need a hip replacement." Like, and then, but there's people who can have like mild narrowing, but they can have a ton of pain. And what actually the reason for that is, if you do an MRI on them, you'll find something called synovitis and bone edema underneath, and that's chronic inflammation, which can cause pain. And so what we do is we drill a little bit into the bone underneath the cartilage, and we inject the PRP.
Oh man, if anyone like true pain to me is like periosteal pain. If anyone knows like true pain at the periosteal, I got you now. Can you hear me?
All right, I think we're back.
Yeah, no, like periosteal pain is like the worst pain ever. The second you say bone injections, all I think about is like the Incredible Hulk movie with Ed Norton, where they make the abomination with the big needle in the spine, and it's like, oh. Well, that brings up another point too, actually, that because I've seen Instagram videos of powerlifters getting injections into the spine unguided. Now, like, I just play a doctor on Instagram, and I'm just really happy to have a real doctor with me today. Like, that's got to be a fucking concern, just to be like throwing darts into the spinal cord.
Exactly, and that's the problem. The standard of care, there's so much variability, and there's research to back this up, that image guided outcomes are better, and there's less complications. Like, no duh. Like, no duh. Like, I don't know why we need research for that, but it is what it is. So at least when people argue with you, it's like, oh, I have 30 years of experience, I can do this unguided. It's like, well, there's always that chance where, especially in the spine, you can have what's called intravascular injection, and you inject into a blood vessel and someone has a stroke, and that's how epidurals go wrong, right? And that's why they get bad reputation. But if you do it image guided with like an X-ray device or ultrasound guidance, like, it's very safe and there's very minimal risk. But that's the problem. And patients, they don't have that. Like, a lot of physicians don't have that. Like, a lot of family doctors don't even know that, right? And so, how can you expect a patient to differentiate between someone who's doing it properly and who's not? So.
Yeah, it's like, even where, like, I had a friend of mine, his wife, when they had their kid, had an epidural, and I would imagine those are guided, but even after the fact, they had like it's not orthostatic. She was leaking cerebral spinal fluid from the epidural injection site, and basically her brain was starting to rest on her skull.
Oh yeah.
And I was like, that's got to be like something that you would take into consideration, because I don't think most people would take into consideration like the sealed nature of the spinal cord as a unit as it travels into the brain, and cerebral spinal fluids are just like poking holes in it. Like, oh shit, it's not like finding a fucking vein.
No.
Right?
Yeah,
donating blood.
Well, that's the thing. I mean, they do epidurals in the hospital unguided, like, because the anesthesists are pretty experienced with that. But they're also not injecting like medicine in there, so it's a little bit different. But definitely, if you're getting it done for like pain purposes, you should definitely have it guided, just because you're usually injecting like cortisone or PRP, or some people inject stem cells, like all those things. The problem is, if they go into a blood vessel in the spinal cord, you're going to have a really bad complication, right? So you got to make sure you're in the right spot.
Well, how much do you think of the misconception around regenerative medicine comes from maybe a misrepresentation of pain as like a phenomenon or a science?
Yeah, that's a huge part of it, right? It's like, a lot of people think there's one pain generator, and if they just target that one pain generator, they're going to be fixed, right? And the reality is, pain, it's a
put a TENS unit on it.
Yeah, exactly.
Put a TENS unit. Really fine. We're gonna block the pain gate theory. Yep. It's like, thanks, appreciate it. It's 1945 again. What the fuck?
Yeah, exactly. And that's the problem, right? And a lot of pain doctors and sports doctors, and they're guilty of that too, right? They just want to, because they're trained in that model where it's like, okay, we can identify one structural issue, and as long as we target this, you're good to go. And that's where I think you have to look at it from a broader paradigm of like, the other factors, especially like underlying mechanical factors too, which is obviously where like your area of expertise is, but that plays such a big role. Because I can fix your shoulder tear, but if you don't fix your damn scapula and like, you know, all those movement patterns that you have, you're just going to end up injuring it again, or you're just going to like your symptoms won't necessarily get better, right? So
yeah, and I think when you like describe like how, because when you take away the adamantium component of like the healing process, you start to see more of like a marriage of like regenerative and manual medicine kind of coming together. Because like if it's just, you know, proliferating internal signaling cells that are already there or just now in higher concentrations, it's almost like I look at it somewhat like a vaccine almost, where it's like, look, we're kind of attenuating and prepping your body, but kind of in reverse. Now all of a sudden the structure function relationship doesn't become as broken, where like manual therapists deal just in function and kind of like turn a blind eye to structure because they don't really have a say in the matter, right? Like they don't really have a say in like, you know, the inflammation internally. Someone could be like, oh, take turmeric or some bullshit like that. And you're just sitting there just fucking beating your head against the wall. Like, Jesus Christ. It's like, yeah, I'm just going to go have some like Indian food and put some cumin on it. Like, get out of here, that nonsense. But now it's like, I think it opens the door between like two fields of medicine that have been kind of divided for the past, since their inception, really, in like manual medicine and regenerative medicine. Because now it's like, look, we're kind of meeting in the middle to be like, look, there's some structure that can't be outfunctioned, right? Like, yeah, you got to fix your damn shoulder blade, but if there's not a single muscle attached to the shoulder blade anymore, it's like you might want to have someone put that back together first before the rehab starts, which I think is like a conversation that hasn't really been on the table in the past, or at least in recent history. What barriers of like conversation or like what objections do you have to overcome when you're kind of discussing what you guys do with other therapy modalities that just don't get it, like with physical therapists or with chiropractors, or even with like, I don't know, would orthopedic surgeons stand kind of opposite to you guys and not understanding fully regenerative medicine?
Yeah, most of them aren't really trained in that, and their scope is more invasive surgery, whereas ours is minimally invasive surgery, which is the whole goal is to avoid surgery. So, for example, treating a meniscus tear or a shoulder or rotator cuff tear with using PRP or like the fat scaffold, like the whole point of that is that we can regenerate the tissue and heal it without the need for surgery, and then you can work with like a good therapist to kind of rehab and strengthen it, and then you're good. Usually, most of the time, we can avoid surgery. So, orthopedic surgeons are kind of, you know, they were to, you know, obviously there's a little bit of turf war with that stuff because they don't like the idea that, you know, what was once needed surgery doesn't need it anymore. So, but it's going to only broaden because it's patient preference. Most people don't want surgery if they don't need it. And there's a big demand for it. So I think it's a really growing area, and it's going to keep growing. And, but with therapists and like, yeah, I mean, you know, the problem as you know, is like a lot of therapists, unfortunately, aren't, you know, they're trained in a lot of passive modalities, and a lot of kind of that's just where they come from, and like working, you know, just making someone sit on a table and work on them for 30 minutes, hook them up to some acupuncture, laser, ultrasound, and, you know, call it a day. And unfortunately, that's kind of the standard of care in Canada, and it makes it really difficult sometimes because even if I fix their structural component, if I don't have like a competent therapist who can functionally get them back to their, you know, to a high level of performance, it's not going to get the best outcome, right? So that's where a good program where you're progressing them from range of motion to isometrics to strengthening and having more of like a corrective component to it and all that stuff is important. But
so walk me through it. Okay, this would probably be a very real life example. Say I'm sprinting for whatever reason, I have to run, and pop goes the hamstring. I limp into your office. Give me like the process of like from examination or assessment to intervention, healing time. Like what does a day in the life look like for you when you interact with patients kind of in the regenerative medicine field?
Yeah. So basically if someone came in with that, like, yeah, we would first, you know, get the history and then take a look at the area, examine it and see if there's any bruising or hematoma. Cause a lot of times, especially with those acute injuries, you can have hematomas and they can affect the healing of the muscle tissue. And then it can cause something called myositis ossificans, where you get calcification of the tissue. And I've seen that a few times. It's actually really sad because, again, like the standard of care here isn't the best. And what will happen is they'll be referred by their family doctor to an orthopedic surgeon who doesn't, and most of them aren't trained in ultrasound, and they don't have an ultrasound available to them. So they just kind of say, oh, it's a muscle strain or a tear, or whatever. Just rest it for a couple of weeks and you'll be fine. But for us, it's kind of different. So we'll do the physical exam, and then we have our own ultrasound. So we'll take a look and see what's going on. So we can right away assess, if there's a hematoma, usually we'll drain it, so that the healing can be better. And then also to look at the grade of the tear. So there's, tears from grade 1 to like grade 3. And obviously if it's a fully detached tear, that's, typically you need an MRI and get surgery. But most tears that we see are like grade 1 to 2 type of thing. And sometimes if they are full thickness, but the tendon isn't retracted, and you just kind of like have a defect, like a hole, we can fill that hole too with like the scaffold that we talked about earlier, like the fast scaffold. So what we'll do is we'll do the ultrasound and decide, what grade is this, and then see from there, which treatment is most appropriate. But typically, if it's like a grade 1 to grade 2, which is the most common, most people, I would say in my experience, most people like to get PRP done because, especially the patients who see us and high performance athletes, they want to get back to playing sport, right? As for the quicker, the better for them, especially if you have like a pro, like for example, we see pro basketball players and stuff like that. And for them, a couple of weeks can make a big difference. And so they'll want to usually do something about it, some intervention. And that's where the PRP typically comes in. So for example, if we had someone like that, we would drain it, and then we would, find the damaged area, and then we would take their blood, we would spin it in our centrifuge, and then we would inject the PRP with ultrasound guidance directly into the tear. And typically we'd want them to be rest for about 48 hours, and then we get them on like a range of motion, usually like a light range of motion isometric program for about 2 weeks, and then bring them back for a follow-up. And at the 2-week mark, a lot of times with the PRP, you can actually see the tears almost fully healed, which is amazing, because usually it can take 4 to 6 weeks, or sometimes like these, sometimes tears don't even heal for whatever reason. And then people have like chronic injuries. And then at that point is when we'll get them on like a more strengthening program to get them back to return to, play and all that stuff.
You mentioned something interesting that is so widely perpetuated with like mom science, and that's like the draining of like a hematoma or like bruising. Like if it starts to swell, the majority of people's thought process is that can be like, leave it, because that's like the body doing its thing. But like the idea of draining it seems almost, in a lot of people's eyes, would seem almost counterintuitive. It's like, oh no, like that's healing and all that. Where does that science come from, or in what ways is that right, and in what ways does that be at what
there's a fine line. Like, if you have a little, I think that's where the imaging is really important, because if you have a little bit of bruising and swelling, that's normal healing response. But having a large hematoma is typically concerning, because it can really affect the healing of the tissue, and especially if it's like say if it's 1 to 2 weeks out and it's not getting smaller. It's not, you don't want to just leave, like that's the problem. A lot of people are like, oh, it's just normal, it'll go away. but after a couple of weeks, you should probably have it looked at.
Well, dude, I had an MRI on my pec when I tore it, and like it was obvious that I tore a pec. Like I know what a pec is, and there was so much, and I got in right away because I was pulling rank. I called that imaging center. I was like, yo, I send you like 20 G's a month. You get my ass in right now. And so they got me in, and I got the results back the next day. But there was so much fluid in it. Like it was bad, real bad. Like I was bruised from my wrist down to my pelvis. And there was so much fluid. The only thing I could, discern in like kind of clinical findings was a partial tear of the subscap. I'm like, this does not happen from a partial tear of the subscap. But I called the guy and I was like, are you serious? He goes, look, man, like that was the only thing we could put definitively, because there's so much fluid. So from a diagnostic perspective, even just being able, because they didn't have an ultrasound or like a guided ultrasound, even from a diagnostic perspective, if I would have got it drained, I probably would have had a more accurate
Exactly. And I had one case of a powerlifter, same story. We drained it for him, and he got the MRI the next day, and it diagnosed it. They diagnosed a full thickness tear, but it was much easier for them because we drained it.
Yeah, that signaling, that T1, T2 weighted in the MRI, like it's just gonna light up like a Christmas tree. You're gonna not see nothing but a bunch of white fluid that's not meant to be there. Where do you think? I mean, we talked a little bit at the front end of this. Like, what do you think the future is? Like, if you had to like invest stock into, like you talked a little bit about second gen PRP, we alluded a little bit to peptides, the misnomer around stem cells. Where do you see where is the research headed? What are the promising frontiers in regenerative medicine?
Yeah, I think the research is really headed towards more of like a precision type of medicine, where you're making like a regenerative solution that's more specific to the issue. So like we're talking about with the second generation, right? It's more specific to chronic inflammation because it's targeting those, it does a better job at targeting the chronic inflammatory cell signaling that causes pain and inflammation. And so I think, as we evolve, eventually I think there'll be a third generation that'll be where you'll be able to take someone's blood and you'll be able to take samples of their tissue, and then to say based off their tissue sample, you can see which, for example, if they have a lot of IL-6, which is interleukin 6, or if they have a lot of MMPs, then you can say, okay, we can make a PRP solution that targets these inflammatory molecules because this is what this patient has more of. And so I think that will be the third generation, and that's kind of where we want to take the field as well with, Dr. Gallia, who's like a pioneer of the PRP stuff, and he's the one who invented the second generation one, and that's where we would like to head with the third generation eventually. And I think so that's the PRP, and then I think the regenerative component of regrowing tissue, the big thing is really going to be 3D bioprinters. That's going to be the coolest.
Explain that one for me, because you just went from like Iron Man, or you just went from like Wolverine to Iron Man, because that one I've looked at it, I kind of understand it, but then I think about it for 10 seconds and like the red wire touches the blue wire, my brain just goes, nope, this doesn't make any sense.
Well, the framework is, remember, there's a scaffold, there's progenitor cells, or like the capacity to regenerate into something, and then growth factors, right? So that's a cell proliferation triangle. So just remember those three things. And basically what we're trying to do is we're trying to create a scaffold, and that scaffold is going to be created via a 3D bioprinter that can essentially act as like a conductor for the stem cells and the growth factors. To kind of, and then that can differentiate into, like, for example, cartilage or meniscus or whatever you're trying to regrow. But that 3D bioprinter, the issue and the area of kind of research is what's the best scaffold. And that's kind of what they're trying to figure out. They've used different things, but it seems like based off like it seems like hyaluronic acid, which is the stuff that makes up collagen. And that's also part of cartilage too, right? It seems like it has a good conduction capacity, and it seems like it holds well. And so that I think that's probably the most promising at this point.
That's got to be like a really like kind of a touch and go field, because what you kind of described was almost like the way antibiotics progressed, or at least how I see from the outside. Antibiotics went from like broad spec to very specific based on the type of bacteria that you had, right? So it seems like a very similar thing.
That's a great analogy.
Well, but I'm an outsider. Well, it's funny. I have a buddy from Windsor who's a shark fisherman. Really strange story, but like he's from Windsor. He used to work at Home Hardware with me when we were like 16, and his dad had a condo in Florida, and he started fishing for shark just because he got bored, and so he caught a few like small ones, and the small ones turned into big ones. And he got contracted by University of Florida, Miami. And his job was to catch sharks so they could swab the teeth of the shark to be like, hey, this is the bacteria that shark have when people get bit by sharks, and we know how to better give them an antibiotic. So that's kind of like when you were saying that, I was just thinking of like my buddy sitting there reeling in sharks and swabbing the teeth for. But it like, because we see this in the pseudoscience world and like bodybuilding community around peptides, right? Like, oh, if you have a muscle tear, you take BPC. If you have the bone issues and tendon issues, you take TB500. Where is the regenerative medicine, if at all, looking at like peptides, and what is like the legal and research limitations on these compounds?
Well, yeah, in Canada, there's a lot of regulation around that stuff. Essentially, we can't do we can't prescribe it. We can't really, no one's really researching at this point. We're trying to be the first, with our scientists, we're trying to be the first team to try to set up a research study in Canada. But in the US, as you know, Dr. William Seeds the orthopedic surgeon. He's pretty well known for that stuff, and he's done, he's done quite a bit of experimenting. I don't know how much research he's published on it, but I know he uses it a lot for his patients, and that's the problem. A lot of it is anecdotal evidence, and right now it's pretty low level, and but even so, I can say based off my anecdotal evidence with patients, like I had a pro bodybuilder who had a biceps rupture, and he was taking BPC 157 during his post surgical healing, and both the surgeon and myself were amazed at how fast he basically healed with was fully back to working out within like 4 or 5 months, and often it can take like a year before for a lot of people to be like fully functional and strength.
Yeah, and what I've read, it seems to follow a lot of the principles of like the actual thing that PRP actually does. Not the thing that people claim PRP does, but like the signaling regeneration, it just seems to be very like specific.
Yeah,
like,
exactly.
I've read a study. Yeah, I've read a study about like a PCL in a rat, and obviously like rats, humans, not even to mention like biases and how lab rats are regenerated in labs and evolutionary problems with lab rats, but like. I think it regenerated, and I might be fucking this up, but I'm pretty sure I have a study somewhere. It regenerated a PCL in a rat that was severed on purpose, like grew it back together. And it's not like, hey, you now have a bone where your eye used to be.
Yeah.
But it's like, what do you think from like, it can be difficult, I'd imagine, being on the leading edge of research, because you have to be like, your lawyers have to be one step ahead of you. Like the lawyers in the clinic, you can't do that. Just give it like 2 weeks. Like you wait till this bill to get passed. What are like, when you guys deal in the med legal world, what's the big concern with peptides? Like, what is the potential downfall? Because it seems like you can't do the research until you get the law, but you can't get the law until you have the research. So it seems like almost a non-starter.
Yeah, exactly. And I think it's just Health Canada regulation that I think, honestly, most of it's just ignorance. Like the people who work there don't know that much about it. And so they just kind of, instead of trying to figure out, just like with stem cells, instead of trying to figure out the nuance behind it, they just kind of say, no, you can't do it at all. And that's where we have to work with our scientists and with our lawyers, basically to propose to Health Canada why this is an area of research and why we should, study this further. And so, for example, with the stem cells thing, there's a group out of BC that's actually fighting with the Supreme Court, essentially to tell Health Canada to not outright ban all stem cell use, that there should be specific uses for it based off the research. And so that's where I think you have to have a more nuanced approach instead of just like us. Basically, they just don't want to look into it and just be lazy and just say, no, you can't do it. And so that's where we have to, and that's where our work comes in. We have to essentially put a proposal together to say, there is evidence, for example, in rats, and anecdotal evidence, and it's worth pursuing research. And I think, it works. I think it would be work great synergistically with like PRP and like stem cells, the peptides. So
yeah, I'd spoken with Doc Seeds about it a year and a half ago, and he's, judging by his bow tie collection, quite like an eccentric dude. But he was saying that they were doing it in surgery, and I was like, this sounds like a good thing I'm not wearing a wire, because this sounds highly illegal. But do tell me more. And he was saying that they would like actually douse a surgical site. So in the anecdotal evidence that he kind of brought forth in this talk that he did, one was like the Tom Brady one. I don't know if you're familiar with that.
I've heard of it, but I don't know the details.
Tom Brady, and this is like where Tom Brady sliced his hand on a knife during the Super Bowl, which is like, let me guess, your wife got mad and came at you with a butcher's knife. You're Tom Brady. You're not washing the dishes. Like, that's for bullshit story number one. And they use electrophoresis and like one of like the major, more popular BPC or TB500 or a combination, along with electrophoresis. And in 2 days, his hand was back to normal. They actually got, which is really weird, because they got a medical exemption from the NFL to do it, which is like, okay, the NFL is superseding the law and creating. Yeah,
exactly. It makes no sense. Right. Well, that's the issue, right? The FDA. If the FDA found out about that, I'm pretty sure he'd be in trouble. But it is what it is, right? FDA can't oversee everything, but the FDA has actually come down on peptides recently. They've put a lot of injunctions against a lot of clinics that are offering them. So they're starting to regulate them a lot more. So I think there's going to be more issues for doctors who are doing it in the States now.
Yeah, I mean, what was it? Dancing with the Stars, I think is what, like, Doc Seeds was on ABC. Because and they were showing it like on prime time, 5 p.m. One girl like rolled her ankle, and he showed his presentation, was stoked off it. I was just like, you're going to get indicted, but this is brilliant.
Yeah, exactly.
But like, you treated the ankle, I don't know, as anterior talofib or something like that, rolled it pretty hard. Some little dancing chick with heels, there goes the ankle. And he was like telling us how, like, pre-op injections, dousing it with, and the results were insane. Like, obviously there might've been things going on that we weren't privy to, but like, similar to the way that you looked at that bicep tear and like, well, anecdotal or not, this is pretty considerable, right?
Yeah.
But yeah, it's just odd to see something that shows so much promise being held back. But then this is cyclical though. Like, I remember, like, to me, it seems like it came in waves, where it was like stem cell was first in, and then it was PRP, and now peptide seems to be like the new frontier. And it's like, we seem to be kind of just this coming in waves. Does one seem more promising than the next? Like, would you say signaling, like getting better signaling for PRP specific to, the tissue involved, the person it's in, the framework or the lattice work it has to be built, is that in your mind more promising than like maybe opening up the legal door to peptides?
Well, yeah, I think cell signaling is the future for sure. Like, in terms of figuring out which cell signals you need to basically activate depending on the issue. But having said that, I think that cell signaling can be like essentially like optimized or increase with the growth factors that the peptides offer, because the peptides work more like a general type of like just accelerating the healing process, and then that works well with essentially like any regenerative procedure that we do. So I think it'd be very interesting, and this is a study I'd like to do, is what we're trying to work on, is to do a study where we have a group with people who have acute muscle tears, and we have people just do regular PRP, and then we have people who do PRP and, like, for example, BPC 157, and then see which group kind of heals faster. And I think we would definitely see people with BPC 157 and PRP do better than just the PRP alone.
So PRP is going to be PRP is the mainstay in your mind as far as regenerative medicine goes?
It's the most like versatile, and it can be used with scaffolds and with stem cells so it can and it can be like, because of second generation and eventually third generation, there'll be more there'll be more better versions of PRP. But like you said, like, it's almost like the antibiotics, right? At first PRP was just this, and a lot of clinics still do that. They just have like a general centrifuge and they just spin it, and they're like, yeah, we're just going to inject this, and they don't even know what they're injecting. You can ask 99% of clinics in Canada. Actually, we're the only clinic in Canada that has a scientist that actually measures our platelets and our cells and our molecules. We have a cell counter. We're the only clinic in Canada that does that. So there's no standard, right? And that's the issue, right? People are just like spinning blood and injecting it, and they're like, oh, hopefully it works.
Good luck at the Tour de France. Good luck out there, guys.
Yeah. So, and that's the issue, right? In the US, it's the same. US, there's a few guys doing it. So there's Regenix and Dr. Sampson in LA, and there's a few guys who measure their cells and stuff. But but still, it's a very low standard, right? Basically, it's like, it's not very precise, and it's just like, yeah, we're just going to take your blood and spin it and hope it works. But and that's where the controversy comes, right? It's like, oh, PRP doesn't work, and you'll hear all this mixed information. It's not that PRP doesn't work. It's that you need a specific, almost like cocktail, depending on what you're trying to achieve. And that's why we have all these different kits and centrifuges, and we measure our cells and all this stuff. And so there's a lot more nuanced science to it. And I think an interesting example is, for example, if you have someone who's like 75 and is a smoker, you'll find that they have a lot less growth factors in their cell count than someone who's like 35 and healthy. And so that 75-year-old's PRP is obviously not going to have as many growth factors as someone who's 35. And so that's why someone who's 75 it's probably better to use the second gen one, where we actually modified and remove some of those catabolic cytokines and standardize it a bit more.
Interesting. What behavioral things do you guys promote? Like, if someone's injured and like can't get to regenerative medicine, it's a grade 1. Is there like I know there's probably a larger market outside of what you guys do than what you guys do, right? Like the market with like tape, like kinesio tape or ice pack or heat or TENS. Like I get a Theragun question a day. And I just want to take one of those and like 310 to Yuma it and blow my fucking brains out. It's like, is there anything people can do? Like if they don't have access and they do have minor grade tears that, you know, they don't have the resources or don't have the access, what are things that like people can take or do? What is efficacious? What has bad science? What are people perpetuating that might work? What are people not talking about that would work?
Yeah, I think what a lot of that, I think a lot of that laser, like that passive stuff that physios do, like, you know, the laser and ultrasound and that kind of stuff. I think the science on that is not great. And but unfortunately, so that's one thing. And in terms of what, a lot of people can do to kind of accelerate the healing process is just, honestly, it's like basic lifestyle stuff, really, right? If your sleep is crap and you're not recovering, like it's gonna take longer for a strain to heal, right? If you eat like crap and you don't move your body properly and like you're stressed all the time, all those things are going to have inputs in your body that are going to affect the healing process. So I think those are like actually the fundamental things to focus on, and not get, all these weird supplements and all these like Theraguns and all these other things where, they maybe they increase blood flow to the area and maybe it'll help with healing. Like, I don't know.
So you're such a professional. Like, I love that. Like, I'm a fake Instagram doctor, so I can say it's bullshit. You're just kind of sitting here all diplomatic.
Yeah. I try not to splash on people's beliefs too much. I usually try to look at the harm and benefit of any intervention. And if there's very little risk of harm, generally I won't tell them like, this is stupid. I'll just say, if you really want to do it and you feel strongly about it, then that's your choice. And so
I mean, there's something to be said about that though, right? Like the severity of, and even to like, maybe because likely the clinics that are doing that, they're not testing the contents of the blood, they're just spinning it around the room and throwing it back in. The very fact that pain, like you mentioned earlier, has like kind of the psychosomatic component to it. The very fact that someone's like touching their knee and then stabbing that knee with a needle, it almost doesn't even matter. Like I've seen research on sham surgeries where they cut the wrong knee, or like they just slice them and sew them back up. So I mean, it's not to discount it entirely, but if it makes you feel better, that's kind of what we're in the business in. But from the hard science perspective, like it must be difficult because there is so much science in regenerative medicine that someone comes in with like, some of these DeWalt looking Dremel vibration guns. They're like, it's like, dude, 2 of those together has got to be like an injection, like cost of an injection. Like, go buy $700.
Yeah, exactly. Yeah,
because it's like in LeBron's fucking locker or something. But like they won't. I don't know. It's silly to me. I can only imagine how frustrating it is for you.
Yeah, exactly. Yeah, no, and I mean, LeBron is a funny story because I work with the doctor in the Beverly Hills who treats him, and he essentially gets $1 million worth of like treatments a year based like based off like his like team of like massage therapists, like Theraguns, like rehab, shockwave therapy, like, and then he gets stem cell injections during the off season for his knees, and like so he spends like, people don't realize how much these guys spend on their own bodies just to maintain them, and that's one of the other things I think a lot of people don't take into account. They're just like, and I'm sure Brady does the same. I don't know the details about him, but I know the details about LeBron, and he's like, they spend a lot on that kind of stuff.
Now, how much of that and like, this is obviously like subject to opinion, but I mean, I hear that, and like, I've seen videos go viral of LeBron training, and it's like, look, he's not meant to be a professional weightlifter. He's meant to be a professional basketball player. But how much of that do you think is overkill, and how much do you think like is actually substantial? Like I can understand like PRP in the knees, you're 6'8", 280, you run a 4.5 40 and you're just going hard in the paint for 82 games. Like, yeah, that I can see, but like, bringing the Swedish or Thai massage girl on the road, it's like, Ron, maybe call it a night, man. Like, I don't think you need that.
Yeah, exactly. It's just one of those things where it's one like you said, just if people feel better from it, they're just, he probably just does it because he feels better from it. I don't know how much of a difference it would make, but I definitely think there's definitely a component of of like self maintenance for those high performing athletes during the off season. Like what a lot of our NHL pro guys too, they come in during the off season for knee injections, or hip injections or wherever their issue is. Because those hockey guys, a lot of them are really beat up, especially after like some of the vet guys, like their bodies. It's actually funny. Sometimes we have to hide the MRI results from because it's because they're getting contracts renewed and they can't like they don't want to leak out that that their body's actually a mess. And so
that they have two labrum tears,
yeah.
FAI, cam and pincer on both hips. Yeah.
So
is there an athlete or not an athlete individually, but a sport that you deal with on a regular basis that seems to be the most like which one based off your profession? If you had kids, you'd be like, no fucking way are you playing that.
Well, as much as I love gymnastics, the coaches here are insane. Like they put those girls through hell, and we see so many gymnasts get injured. Like it's just like
Really?
crazy. Yeah, like young gymnasts, like it's just injury rates just seem so ridiculously high. But I think a lot of it is because a lot of these coaches are like from Russia or something, and they're just like crazy. Like they just make them do these ridiculous training programs and don't give them breaks, and then but that's actually but having said that, I think if I would still put my daughter in like a good gymnastics program without a crazy coach, just to get the fundamental movement patterns and that kind of stuff, but not to like the point where she has to compete and stuff, because that's where it goes crazy. That's where it goes wrong.
I never would have guessed. I would have thought like soccer or like football or something.
Yeah, no, I think maybe it's just here, but those gymnasts, yeah, their bodies get I've never seen so many girls get injured as any other sport as that.
Now, what about on like the cognitive side? Now, like with in the last 10 years, there's been a huge crackdown, like on the head contact and hitting the head in hockey and football, major combat sports. Now, obviously, like the emergence of concussions in things like UFC and things like that. Is there a place for regenerative medicine, stem cells, PRP, like blood-brain barrier? Does that stuff have a future in like concussion and more neuro symptoms?
There is early research on people using basically there's these specific derived stem cells that are more for the brain that have trophic factors and growth factors to help essentially with neuronal injury. But I think at this point it's really early stages, and there's probably it's one of those things that you could probably find a clinic to do it for you, but there's not enough evidence at this point to really say it has a lot of efficacy. But there's people offering it, like tons of clinics in the US and in Asia and Europe. But I think at this point it's still I think we need a lot more research for that.
Now, with you and your career, what's your trajectory as far as specialty or focus, moving forward for you? What is your mainstay when it comes to regenerative? Is it all in with PRP? Is it pushing the envelope with peptide?
It's a bit, yeah. I think it's a combination of pushing the envelope with PRP and peptides. I think that's really the future, and combining that, or stem cells and peptides as well, because I think that's where you're going to get an accelerated healing response, and potentially even being able to heal chronic injuries that otherwise would be really difficult to treat. And my area that I'm really interested, I really like the intraosseous stuff, as much as that makes you cringe. I think that's going to be an awesome. It's just an awesome area to treat people with advanced arthritis, and either you can do it in the spine too. You can do it for shoulders, hips, and knees, and so that's a really cool area. And I also I like the regenerative spine stuff a lot too, because traditionally a lot of people with back pain are just treated like we said, just with one pain generator. They're it's coming from your facet joint. We'll just block the nerve there, and then you won't have any pain anymore. And then and so I think I like the regenerative approach because it's a lot more integrative. Basically, for example, what we do is if you have someone who has DDD and spinal stenosis and facet joint OA and stuff like that, they have a lot of stuff going on. We can treat everything with PRP, but basically you do a PRP epidural, you treat the facet joints, And then you actually can treat the multifidus muscles because sometimes they can have chronic tears. And then you also treat the ligaments. You do like a prolotherapy type of treatment for the ligaments. And what that does is it helps to stabilize the spine, because a lot of times it's because of chronic instability that you get those issues in the first place. So it's I like that stuff because it's more, it gives more options to patients and gives them a potentially ability to avoid surgery. And I think it's more comprehensive than just like the traditional approach.
What advice would you have for people like seeking like regenerative medicine practitioners? Like, it seemed like it was a pretty short list of people you'd send like a family member to. But like,
exactly.
That's a question. What does your DM look like? Like my DM is my knee hurts. Where are you? It's like, I'm nowhere near anywhere you are. I can assure you of that. But what advice do you give people who are like, hey, I don't live near you. I have, X, Y, and Z. What do I do? Like, how do you vet these people?
Yeah, there's like, they're starting to have like this. So Dr. Steve Sampson, he's like, he started like a regenerative medicine conference, and he's the one who treats LeBron and stuff in the States. Like when I was down there with him, and he has like what's called an ortho healing kind of database. So he's trying to create this standardized certification for regenerative medicine practitioners, and trying to basically raise the standard in the industry. So if you're looking for someone who's a regenerative medicine practitioner, I think looking for that certificate, basically if they're an ortho healing method provider, that's an easy one to look for in the States and in Europe too, and Asia. They have people all around the world. So that's an easy one to, but yeah, I get DMs all the time, and I there's only maybe 2 or 3 guys I trust in the States, and a handful of guys here and there. But in Canada, there's really, like, not to toot our own horn, but like there's really no one. I mean, there's just no one here who knows their stuff. Like it's just like every sports clinic offers PRP now, and but they ask them if they have a cell counter, ask them if they have a scientist, ask them about second gen PRP or scaffolds. They don't know anything about that stuff. So
see, that's way more scientific, because my feedback is when someone's like, hey, how do I pick a chiropractor? I go, ask them how much they squat. And that's usually my answer. They're like, that guy sounds like a punk bitch. Don't go see him.
Yeah.
Now, what about seeing you guys? Like, you guys are in the GTA. Because, like, I have a handful of guys in the States that are athletes that, they're more than happy to hop on a plane and go. And I know people who aren't athletes who've been dealing with issues untreated for a long time. Like, what's your wait list right now? Like, it has to be in high demand.
Yeah, I mean, we're expanding, so we're able to accommodate people pretty well, but we do have people, just because of Dr. Gall's reputation, we have people around the world who come down to see us, especially with the second gen PRP. Like, people fly down from Europe, they fly down pretty much anywhere in the world. People have come to us. So it's not the wait times aren't unreasonable. They're generally like a month, but it's not like, we try to be pretty good with it, and especially if they're coming from out of country and if they're only here for a specific time. Usually we're pretty good at accommodating people. We want to, and I think in the States, the issue is there's so many people doing it. It's really hard to figure out who's doing it properly. In Canada, there's maybe not as many people, but they're just doing such a bad job that it's like, I wouldn't recommend anyone else.
Dude, yeah, it's funny because I first got on to you guys. I mean, I'd heard of you through Omar. I've heard of you through Dorian. And it wasn't until I needed you guys when I tore my pec like 3 years ago. And I called Ben Pekalski. Like he was my first. I didn't even call my mom first. I was like, I basically just regained consciousness, realized I was in a bad way, and I was like, hey, I know who'd be able to like at least know someone to fix it. And then first words out of his mouth were, "Hold on, I'll call Gallia's clinic." So I mean, if that's as for me as sterling a tip of the hat as you can get when it comes to that kind of stuff. Now, obviously, DM is not the preferred method of communication for booking appointments, as I come to know, and I'm not nearly as a professional as you. What's the best way to reach the clinic, and then the best way to reach you?
Yeah, I mean, I'm pretty good on Instagram, so but yeah, DMs are terrible. So but my Instagram is like dr.akhan, Khan. So Dr.Akhan, and basically my email is on there. It's just the word doctor spelled out. adeelkhan@gmail.com, and I give out my email publicly because I was inspired by this orthopedic surgeon named Dr. Brian Cole, and he says he gets 130 emails a day and he responds to every single one. So I try to make that my goal as well. So I do respond to every single email that I do get. So if you email me, I will definitely respond. But if you DM me, I will unlikely respond. So
Yeah, I like your Instagram just because of the gnarly shit you put up there. You sent me that like fat injection shoulder thing, and I was like, it took me probably like I had my phone on the other side of the room, and I was just like peeking over at it. But yeah, no, I appreciate you taking the time to come on, man.
Well,
Definitely when we get back into GTA, well, I want to make this kind of a thing, especially with
yeah,
like your affiliate.
when we do the intraosseous injection, I'm going to do one hopefully next month. I'll make sure I tag you. Because,
Oh God, it's like the funny bone pain. Like
yeah.
I've had some falls, and I've had some like, playing hockey and sports where you're like, it's a bone pain, like bone edema. And I've seen it like, the worst presentations I've ever seen of pain. You can see bone edema like on an MRI, like fairly easily when it's bad. And it's just like, it's almost like reminds me of those old Shaquille O'Neal commercials where there's just like this weird throbbing, like on like the little diagram, like Shaquille O'Neal was doing like icy hot patch things. And it's like, yeah, I'm going to listen to Dr. Shaquille, not Dr. Adeel. And it's just like, you can see just, oh fuck, it's the worst. But yeah, I'm probably going to throw up in my mouth when you do that. So thanks in advance for that. But no, I do appreciate you taking the time, man. I'm back in Toronto in September. And we will definitely be seeing more of you in some capacity, especially with the HD stuff. So I'll put all the show note or all the links in Instagram and all that stuff, websites, emails in the show notes, man. I really appreciate you taking the time.
Yeah, no, thanks for having me. Hopefully you learned something useful and your audience did too. So it's cool.
Oh, well, this is all for me. I don't care about them. I have plenty of more questions.
Awesome.